Assalamu alaikum. So my first point to be high, just give me a second, please.
Sir, I have two more questions.
Okay, please go ahead.
सर रिसेंटली एक केस मैंने करवाया था. ही वाज अ पेशेंट ऑफ अनकंट्रोल्ड हाइपरटेंशन एंड ही हैड अ हिस्ट्री ऑफ स्ट्रोक 20 years back. Now he came for just lab chole. So sir, for this kind of patient we have to do whole neurological examination अगर ऐसा कोई पेशेंट
Okay,
लॉन्ग
what
केस में आ
what
जाए.
surgery? What surgery?
सर फॉर लैब कोली.
Lab coli. Okay, stroke how many years ago?
सर 20 years.
20 years. Any residual?
Yes, sir. He has right side upper limb and lower limb weakness.
Right side weakness. Okay, is he taking any medications for stroke?
No, sir. He was non-compliant patient. He wasn't
What do
taking
you?
any medicines.
So that's a dangerous thing. Okay, so non-compliant. Okay. So, like, what you want, what you'd like to ask in neurological outcome? Like, you can say, what do you think, other than this right side weakness? What else? What are the other problems?
Sir, other than that, I can ask for his macrovascular and microvascular complications, but he had already macrovascular complication.
No, just a second. Just what type of stroke it was? Was it ischemic?
Sir, or any autonomic, sir, at any autonomic changes,
अच्छा,
any sort of motor deficit or sensory
जस्ट अ
deficit.
सेकेंड. आई थिंक वी विल कंटिन्यू आवर मोड इन उर्दू, क्योंकि मेरे ख्याल से अभी कोई ऐसा बंदा नहीं आया है. लेट्स डिस्कस इन देसी माहौल. आप मुझे ये बताएं कि, एक मिनट पहले इनको बोलने दीजिए, फिर आप नोट करते जाएं. अब मुझे पहले ये बताएं कि स्किमिक स्ट्रोक और हेमरेजिक स्ट्रोक, इसकी पिक्चर में क्या फर्क होता है? फायजा, आप बोलना चाहती हैं?
Sir,
जी, आप बताइए उसको कौन सा था
uh,
उस पे. बाय द वे, अच्छा, हसाम, बेसिकली ये आपकी ही वो विश पूरी हो गई है. लॉन्ग केस ही है एक्चुअली. ये इट कैन बी अ लॉन्ग केस कि ओल्ड सीवीए. ठीक है, ओल्ड सीवीए का आए तो उसमें आप क्या करेंगे? ये बिल्कुल यही लैब कोली को हटा दें आप. लैब कोली की जगह वहां पर एक पेशेंट हो जिसकी राइट साइड की वीकनेस हो. ठीक है, इस तरह का पेशेंट वो लॉन्ग केस में आ सकता है. ठीक है. हाँ जी, कैसे आप डिफरेंशिएट करते हैं स्किमिक स्ट्रोक और हेमरेजिक स्ट्रोक को?
सर एक तो इन दोनों की कॉजेज डिफरेंट होती हैं. हेमरेजिक स्ट्रोक की यूजुअली कॉज सब एरिकनॉइड हेमरेज एंड इंट्रा क्रेनियल एन्यूरिज्म्स होते हैं.
अच्छा, और हाइपरटेंशन नहीं होता?
सर बेसिकली
यस
सर
सर.
रेडियोलॉजिकल फाइंडिंग के बेसिस पे
हशाम
सर हम डिफरेंशिएट करेंगे क्योंकि
हशाम हशाम,
जी जी सर.
एक मिनट प्लीज. आपको मैं थोड़ा सा, मुझे टाइम दीजिए. मैं आप इसमें कोई जो चीज मिसिंग है आप नोट करें. मैं एक मिनट इनको मौका देना चाहता हूँ, फिर मैं आपसे ही सवाल पूछता हूँ. जस्ट गिव मी अ मिनट प्लीज. या फायदा
जी
प्लीज. हाइपरटेंसिव क्राइसिस का
सर
आपने नाम लिया. हाइपरटेंशन के जरिए हेमरेज स्ट्रोक हो सकता है या नहीं?
यस सर.
आपने सिर्फ सब अरेकेनाइड हेमरेज बोला है और एनोरिज्म बोला है. ये तो एक ही चीज है तकरीबन. सब अरेकेनाइड हेमरेज भी आमतौर पे हेमरेज से ही होता है ना. ये एनोरिज्म के रप्चर से होता है. वैसे तो सबरेकनाइट की बहुत सारी कॉजेज हो सकती हैं, लेकिन वन ऑफ देम इज सेरेब्रल एनोरिज्म. तो हाइपरटेंसिव क्राइसिस के अंदर जो हेमरेज हो सकता है, जो हमारी जिन पे सारी फिल्में बनती हैं, वो ये हेमरेजिक क्राइसिस, हेमरेजिक स्ट्रोक होता है ना. जो वो एकदम से कॉमे में चले जाते हैं, तो आमतौर पे हेमरेजिक स्ट्रोक होता है. ठीक है. जो ये, वैसे तो इसकी बहुत सारी डिफ्रेंसिएशन होंगी, और जैसे शाम बोल रहा था कि रेडियोलॉजिकल फाइंडिंग होती है, लेकिन आम तौर पे ये ग्रेजुअल हो सकता है. इस्केमिक स्ट्रोक का ये आम तौर पे ज्यादा एक्यूट होगा. ठीक है. और बाकी पिक्चर ऑलमोस्ट सेम हो सकती है. इसमें कोई किसी भी किस्म की आप क्लिनिकल साइन सिम्टम्स में आप उसको नहीं डिफरेंशिएट कर सकते, बल्कि जो हेमरेजिक स्ट्रोक होता है वो उस पे भी जल्दी एविडेंट होता है इमेजिंग में। ठीक है, जबकि जो इस्केमिक स्ट्रोक है, इट मे टेक सम टाइम टू अपीयर। समझ आई? तो अगर आप स्ट्रोक का कोड पढ़े ना, वो उसके अंदर जो आपकी जो अमेरिकन हार्ट एसोसिएशन का है, वो मेरे ख्याल अगर आप उसको फॉलो करें तो वो सबसे बेस्ट होगा। वो मुझे ज़बानी याद नहीं है कि वो किस तरीके से उसको सिंसिनाटी स्कोर होता है जिसके ज़रिए वो उसको रूल आउट करते हैं, और कितनी देर में उसको आपने थ्रोम्बोलिटिक थेरेपी देनी है, किन कंडीशंस में आप थ्रोम्बोलिटिक थेरेपी नहीं देंगे। ठीक है, और किसके अंदर इंटरवेंशनल रेडियोलॉजी का रोल होगा। ये शायद ये एक अच्छा टॉपिक है जो आपसे पूछा जा सकता है। तो अगर आपने अभी तक नहीं पढ़ा तो आप इसको पढ़ लें। मुझे बहुत सारी चीज़ें ये ज़बानी याद नहीं है, तो मैं गलत नहीं आपको बताना चाहता, बट दैट्स अ गुड जो है ना, ये पॉइंट्स जो मैंने आपको बताए हैं, इसको आप अप्रिशिएट कर लें। स्कीमिक वर्सेस हेमरेजिक, और किस तरीके से उनको वैल्यूएट करना है, वो सिंसिनैटी स्कोर है, वो आप देख लें। उसके बाद जो है अगर ये तो है एक्यूट, सॉरी, उसकी इमीडिएट, उसकी उसमें मतलब यानी कि अगर वो आपसे डिफरेंशिएशन के बारे में पूछना चाहते हैं या उसकी मैनेजमेंट के बारे में पूछना चाहते हैं। अब ये केस अगर आ गया है कि जिसके अंदर राइट साइड की वीकनेस ना हो, सिर्फ पैरा मतलब लाइक कि बिल्कुल पैरालिसिस ना हो, पैरालिसिस हो, पैरालिसिस ना हो, पैरालिसिस हो। ठीक है, क्योंकि पैरालिसिस वाला पेशेंट तो मूव ही नहीं कर सकता ना सही तरीके से, तो वो शायद ना प्रेजेंट करें, हम आपके लॉन्ग केस में पैरालिसिस वाला आ सकता है। तो इसके अंदर आपका यही क्वेश्चन था कि आपको क्या करना चाहिए। बेसिकली इसके अंदर एक तो बात ये है कि इट्स वन ऑफ द क्लिनिकल रिस्क फैक्टर। ठीक है, क्लिनिकल रिस्क फैक्टर और कौन कौन से होते हैं शाम, अब आप बताएं। व्हाट आर अदर? हिस्ट्री ऑफ सीवीए इज वन ऑफ देम। व्हाट एल्स?
सर स्मोकिंग हो गई, हाइपरटेंशन हो गई,
नो,
कोई वेस्कुलर,
नो, नो, नो,
कॉन्जेनिटल
नो, नो,
वेस्कुलर
प्लीज,
एनोमली हो गई।
प्लीज, 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 प्लीज differentiate between a horse and a donkey. Clinical risk factors,
ओके
I'm
सर।
asking clinical risk factor, which is also called as intermediate cardiac predictors.
ओके
ये क्या होते हैं?
Sir, compensated heart failure
प्लीज, अब
and
आप बोलना शुरू हो गई हैं, अब आप उनको बोलने दें प्लीज, उनको बोलने दें। जी।
सर एक मिनट, मैं बताता हूँ सर आपको। सर कॉम्पनसेटेड हार्ट फेलियर,
कंपनसेटेड हार्ट फेलियर,
अनकंट्रोल्ड डायबिटीज,
अनकंट्रोल्ड डायबिटीज नहीं है इसके
डायबिटीज।
अंदर। नो, 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 आपको
अच्छा
नहीं याद है, आपको नहीं याद है, और खुदा
जी
के
सर।
वास्ते ये आपके टिप्स पे होने चाहिए। और
जी
किसी
सर।
को जबानी याद है पांचों तो वो बोले। हसाम, आपको याद है?
Sir, history of stroke, history of stroke, history of ischemic heart disease, creatinine greater than 2, diabetes requiring insulin,
इंसुलिन डिपेंडेंट डायबिटीज मिलाइटस,
history of heart failure
CRF, creatinine more than 2, compensated
greater
heart
than
failure
2 milligram,
means न्यू यॉर्क हार्ट एसोसिएशन क्लास 1
1,
एंड
2,
2। ठीक है, और आपने स्कीमिक हार्ट डिजीज बोला है, वो भी वही है, स्टेबल
history of
कार्डियोवास्कुलर,
ischemic heart disease,
स्टेबल स्कीमिक हार्ट डिजीज, न्यू सॉरी कैनेडियन क्लास 1 एंड 2। ठीक है, या इसके अंदर आएगा ओल्ड MI। ये हशाम आपकी टिप्स पे होना चाहिए ये। सीवीए,
जी सर।
कंपनसेटेड हार्ट फेलियर, CRF, इंसुलिन डिपेंडेंट डायबिटीज मिलाइटस। अब इनके अगर आपने इन्वेस्टिगेशंस कार्डिक करवानी है या आपने न्यूरोलॉजिकल इन्वेस्टिगेशन करानी है, तो उसके अंदर आपने पहले ये देखना है कि इनमें से कितने उसमें रिस्क फैक्टर्स हैं। ठीक है, डॉक्टर मुतासिम, कैन यू अंडरस्टैंड our language, or should we talk in English? I think I will change my mode, because there are some people who, because we are discussing a patient with uh, like one-sided weakness, and that patient is presented for laparoscopic cholecystectomy. Okay, this is our, so these are the clinical risk factor, other clinical risk factors which are important. Okay, so in on the basis of these things we need both cardiovascular as well as neurological. So I don't think so, I don't remember exactly what is the guideline, but I think if there is a no newly developed neurological symptoms, I don't think so there is any neurological investigation is needed, because whatever is there is there. Yes, for example, if you have a high risk surgery for the like a bad neurological outcome, like for example, if this patient is having this heart cabbage, okay, in these case they definitely do carotid Doppler, to carotid Doppler or CT angio to see the status of cerebral uh, vasculature. Okay, so yes, Assam, few words about it. What do you think for lab chole in a patient with old CVA? Do you think they need a neurological investigation?
Sir, can you rephrase the question, please?
The patient who
I
has
didn't.
a previous CVA, okay, now the patient is going for laparoscopic cholecystectomy. Do you think if there is no development of new neurological symptoms, do you think the need neurological investigations?
No, sir, I think so. We should do a neurological examination and document all the deficits the patient is having, and
Yes,
we should proceed as it is.
yes. And what will be now? Now, I have a question for you. What would be the intraoperative care in this patient? Because what thing can aggravate or have chances of further CVA?
Sir, these patients, if are immobile for a long period of time, they are prone to DVT. Again, the use of succinylcholine should be done with very with very caution. The
Okay,
injuries
what
need to be
else?
documented, and extra care should be uh, given to that to prevent any further iatrogenic injury
Okay,
during
what
positioning
else?
or intraoperatively.
What else?
During the monitoring, we have to take care that we should not apply the
The regional
NIBP on the
anesthesia,
pressurized or paralysis
Dr. Aslam,
regional
side.
please,
anesthesia should be
Dr. Dr.
proceeded with
Aslam,
caution.
please let him speak. I will let you speak. One minute, please. Yes, please. What are you asking again, please? Continue.
Sir, I'm saying that regional anesthesia should be proceeded with caution, keeping in view the pre-op deficit.
Okay, regional anesthesia, preoperative status. Okay, what else?
Uh, you
What
can ask
about
from someone else, I think. So.
maintenance of cerebral perfusion pressure? Is it important?
Sir, yes, sir.
So, would you like to do this more carefully in this patient? And there is now there are O3 I don't remember the exact there is there is non-invasive assessment of cerebral blood flow. So if available, you would like to use it because it can precipitate, and you will have the good anesthesia care with good oxygen, good CO2, like they same avoid hypoxia, avoid hypercarbia, avoid acidosis, sympathetic stimulation, because all these can affect the neurological outcome. Okay. Yes, Dr. Aslam, now please speak out what you were saying.
Sir, good evening again. And during the monitoring, when we are shifting the patient, we have to take care that the paralysis side, just like the left or right maybe. So we should not apply the NIBP or blood pressure or such kind of things to prevent or to aggravate the further injury. So, And
Okay.
we have to take care of that. The IV line should be placed in the opposite side, which is the normal side, or which is not suffering from the paralysis or paralysis. This is the
Okay.
part of the during monitoring. In the pre-medication, midazolam or the to maintain the anterograde amnesia, we can we can give the midazolam and other things and fentanyl, but we have to take care of during the succinylcholine because it may aggravate the there are already extra junctional receptors, so they can be further be prolonged paralysis. To avoid the prolonged paralysis, we have to avoid the succinylcholine
Okay.
and adequate to maintain the adequate CPP cerebral perfusion pressure. We should give the proper adequate hydration or IV fluids to the patient. So we have to avoid the dehydration.
Okay. Hydration is not directly, how hydration is directly related to CPP?
Means sir, we have to maintain the adequate to maintain the adequate perfusion pressure because
Sir, adequate volume status would be essential to maintain the venous
yeah.
return, and that will lead to adequate cardiac output, and that will lead to ultimately lead to adequate cerebral perfusion pressure.
Hydration is related to viscosity. You are telling the right thing, but not in the right way. Hydration is related to
Uh,
viscosity. Whenever there is
to
increased
prevent the
viscosity,
further thromboembolic events or because the increased viscosity due to dehydration may further aggravate the thromboembolic events. So we have to prevent those. Then we have to dilute the concentration of blood. In simple words.
yes, the factors which affect the perfusion, one of them is pressure. Okay, one of them is pressure. What else? The other is hypoxia effects less than 60. Okay. Other factors which affect the perfusion is CO2. Okay. In this case, if there is like uh, decrease in CO2 too much, if you like, because usually in lab chole there is increase in CO2, but sometimes if you are over ventilating high, it can affect the cerebral because it will cause cerebral vasospasm, like it will cause vasoconstriction. So this is another factor. Okay, Faiza, did they ask you anything else? Yes. Faiza,
Sir, I want to
is
ask you a question,
this
sir.
Uh,
just a second.
No, sir. No, sir. This case just uh, comes in my OT, so I was just thinking about it to
Okay.
discuss here.
Okay. Anything else you want to add? Sham, you were saying something?
Sir, basically we can have we can two sides of presentation of the patient. The same patient can come us with without any deterioration of his clinical symptom, and the patient might present with some deterioration of the symptoms as well. So, sir, I was trying to ask that if there is progressive deterioration of the disease, should we go for some any particular neurological or cardiovascular related investigation, or
Yes.
we
Yes.
should go with the same?
Yeah, actually, that's what we I started from. That if there is a change in the, like when the stroke occurred, after that, what is the current status? Okay, if it is any change, of course, you should have the thorough neurological status. Laparoscopic cholecystectomy is now done because the problem is that now it is usually done in the early phase, not like before. Now the trend is that if the patient is presented with cholecystitis or cholelithiasis, it has to be operated at the earliest possible time, because there is a concept that repeated cholecystitis causes more morbidity than uh, doing in the acute phase. Okay, so the concept is now changed. It's now being done just like appendix in majority of the setups. Of course, maybe in Pakistan or in the exam setup, You might have different perspective, but you can tell, as I tell you always, that you should tell in a way that always bring a word of discussion with the surgeon, how much time you have. Okay. And like we have discussed almost all the preoperative neurological status, need of further neurological investigations, presence of other clinical risk factors warrant further investigations related to cardiovascular system. By the way, Dr. Zishan, please tell me what sort of surgery called laparoscopic cholecystectomy is. Is it a low risk, intermediate risk, or high risk?
Sir, it's a low risk surgery, sir.
No, you're wrong. This question, now you should be, unfortunately, you know, I'm really sorry. Just a second, please. I will show you. I tell this thing many times. Just a second, please. What are different low risk surgeries?
Sir, ear surgeries, eye surgeries, any drainage, any incision and drainage, sir, any क्या कहते
Superficial surgery, sir.
sir,
Endoscopic or
superficial surgery.
biopsy or breast surgery or cataract.
Actually, this is purely like you should know. Believe me, this should be in your tips now. Low risk surgery, endoscopic procedures, superficial cataract surgery, breast surgery. Okay, so this is low risk surgery. Intraperitoneal, intrathoracic, carotid endarterectomy, head and neck surgery. Okay, orthopedic surgery. You will find maybe a better text, but you should be knowing what sort of, because this is how you have to elaborate your surgery. Okay, so you should be knowing, is it an intermediate risk, because the American Heart Association, this cardiac patient for non-cardiac surgery, you have to evaluate according to how much is the surgical risk. Four things which you need to know. What are those? One is surgical urgency. Okay. What else, please? What is the second thing? On the basis how you proceed with the algorithm. One is surgical urgency. What is second,
Type
please?
of surgeries.
Uh, surgical risk. Surgical risk. What else? Number three, functional class.
Bleeding and cardiac risk.
No, functional class. Number four, clinical risk factors. Sam, have you seen this algorithm?
No, sir.
Please, you should. I would like to show you. Come out of, but I should say, this Manhus Morgan Sharif. I'm afraid it's there or not, because I keep a number of things. This is the old one actually. This, just, okay. Urgent surgery, you have to proceed. Then active conditions. What are active cardiac conditions or major cardiac predictors? Who will tell?
Sir, it's
Sir,
unstable
recent
angina.
there is a recent or acute MI,
Okay,
unstable angina,
okay,
decompensated heart failure,
okay,
life-threatening arrhythmia.
okay. They don't use the word life-threatening arrhythmia.
Sir, arrhythmias such as AV nodal high block, SVT with hypotension, and uh, and and
Hypotension.
with
Okay, you're right. You're right. I'm
with
just
unstable signs.
I am just pressurizing you. Okay, but you should be knowing the word, because this is everyone, because this question or this format should be there in your mind. If the surgery is urgent, you don't need to do anything. If it's an emergency surgery, you have to proceed with risk stratification. If surgery is not urgent, then you will go whether there is any active cardiac conditions, yes or no. If it is there, you will decide whether you need to fix that cardiac problem first, or you will go for the surgery. Of course, you will go to fix those problems. If active cardiac condition is not there, then the second step, you will see the surgical risk. Okay, if it is low or intermediate, if it is low, you don't need, that's tell you that if is a low risk surgery, even if there is some risk factors, like what will be the interpretation, uh, the interpretation of this word will be that, for example, if there is a patient who is on wheelchair, you cannot assess the functional class. Okay, and this patient is going for insulin drainage. Okay, this is a common scenario for diabetics, and this patient has low risk surgery. Okay, functional class you cannot assess. Would you like to have invasive investigations? The answer is no. You will proceed. Okay, so this is how you will interpret this chart. That if it is a low risk surgery, you just have to rule out active conditions and you will proceed. Okay. Uh, this is what they have written here in details as well. So you will see in patients with one or more clinical risk factor, preoperative baseline ECG may be considered to monitor changes during the perioperative period. But you will not go for further investigation. Then you will see here, you see intermediate or a high risk. Okay, then you will consider this functional capacity. Okay, so if it is more than 4 mats, then again you have to go here. If it is less than 4 mats or you cannot evaluate, then you will, and the surgery is in intermediate or high risk, then you will go for further investigation. Okay, and further investigation is echo, thallium scan, according to different scenario, Holter, ambulatory blood pressure monitoring, and if angiography needed, cardiac CT, and like these things will be step by step. Okay, so आपको ये चीज बिल्कुल क्लियरली पता होना चाहिए. Got it? Assam, आपको did you understand?
Yes, sir. Yes, sir.
So whatever surgery it is, of course, they are not asking you to reproduce 100%. That's why I have made you clear about these 4 things: urgency, surgical risk, functional class, and clinical risk factor. Surgical urgency, whether the surgery is emergent, urgent, or elective. Surgical risk, whether low risk surgery, intermediate risk surgery, or high risk surgery. Functional class, 3 categories: good functional capacity, low functional capacity, or you cannot assess. Clinical risk factors, as we have discussed right now. So, whenever you are asked any question, in whether it is table viva, whether it is long case, please look into these four things. You will assess the functional class, you will look for the clinical risk factors, you will look for surgical urgency, and then you will decide what to do. Okay. Similarly, I was just showing you here that for any surgery, you should know all these things. So, as I have written here, but I have explained to you. Bleeding risk is a little different from surgical risk. Okay. Bleeding risk is a little different from surgical risk. So some surgeries having a risk of bleeding, but they are not too much risky surgery. For example, if you are doing like any surgery in which there is a near that there is a vascular structure, it suddenly can bleed. Similarly, if you are doing a surgery in which you cannot directly compress the bleeding, then it's also a sort of situation in which you cannot control the bleeding immediately. So that these are the something which you should be understanding. What position required, usual duration, level of incision, level of anesthesia required, possible anesthesia option, possible analgesia options, potential concerns and complications, critical steps. Okay, what are the critical steps in each surgery you should be doing? Specific age group prone for that surgery. Okay, any specific equipment, location, staff, medicines, logistics required. So whenever you are thinking they are asked you any surgery, please try to just filter in your mind. Like for example, if they have told you any surgery in prone position, you should be knowing what are the concern. If they have told you any surgery in lithotomy position, you should be knowing what can occur. Similarly, any surgery in which vagus nerve can be stimulated, you should be thinking about bradycardia. Okay, any surgery in which vagus nerve there are more chances of PONV. So that is how you will tune your brain. So this is how this thing and this paper, if you understand, believe me, a lot of things will be easy for you in your any table viva or long case. Cardiac risk, pulmonary risk, renal risk, aspiration risk, PONV risk, airway management, monitoring, blood transfusion required. These are the things. Like for example, if the patient is having smoking, low albumin, upper abdominal or thoracic surgery, okay, or any existing airway disease. So these are pulmonary risk. If the patient is having history of NSAIDs, arthritis, and diabetes, okay, patient taking NSAIDs, okay, or any surgery in which renal perfusion may be reduced, whether it is hypotensive anesthesia, whether the patient has fluid shifts leading to hypoperfusion of kidneys, this is a renal risk. Aspiration risk, any full stomach patient, any patient with gastroparesis, like you can think about all the uh, risk factors for all these things. Okay. So these things should be in your on your tips. What are risk factors for difficult mask ventilation? What are risk factors for difficult intubation? What are risk factors for difficult laryngoscopy? What are risk factors for post-operative ventilation? What are risk factors for laryngospasm? What are risk factors for like like anything? Okay. So whenever you are taking history in long case, Hassam, this is what you need to know. That's not very important what questions you are asking. Believe me, if you understand in a little bit that which question you need to ask for liver, kidneys, brain, heart, respiration, that same thing is cough is there, same sputum is there, same shortness of breath is there, orthopnea, PND, okay? For liver, why same nausea, vomiting, diarrhea, abdominal pain, hematemesis, melena, okay? So see, there are certain things which are very specific, okay? Okay. So Hasham, if you want to ask anything in Urdu, you can ask. I will translate later on. Anything you don't understand, please let me know.
No, sir, there was no particular concern, but the point is that national language affects more effective as compared to English. But
I try to make
that's
it.
the point.
Yes, yes, you are absolutely right. I'm not sure where anyone here right now because I think tomorrow I will definitely take a session in Urdu. Okay, so pardon me for today. I hope you understand. So these things you should be knowing, and I'm very sad that majority of time I have asked question about American Heart Association, these risk factors. Unfortunately, you don't understand. Smoking is a low risk. Hypertension is a low risk. Sedentary lifestyle is a low risk. High cholesterol is a low risk. These are all coming in the low risk. Intermediate risk or clinical risk factor or Lee revised cardiac risk index is the one which we discussed. Active cardiac conditions is the one which you just tell about unstable angina, New York Heart Association class 3 and 4, Canadian class angina 3 and 4, acute MI or recent MI within 1 week, that is acute, within 1 month, that is recent. Okay, and severe arrhythmias. Okay, it's severe arrhythmias which are bradycardias as well as tachycardias. The tachycardias are unstable arrhythmias. Okay, that are the one that is unstable VT, unstable this AF or SVT. Okay, so this is how you differentiate. Okay. Okay, so this is one case we discussed. Uh, just a second. Have you guys prepared eye? So a penetrating eye injury. What are anesthesia concerns in penetrating eye injury? Otherwise, young patient. Yes. Who would like to speak?
Sir, concerns of raised intraocular pressure, concerns of raised intracranial pressure, then increased risk of post-op nausea, vomiting, then any significant risk of bradyarrhythmias, particularly. So these sort of thing I remember right now.
Is it an emergency surgery? So concerns of emergency surgery. Usually this will be an emergency, am I right? Whenever there is any trauma, you have to tell about advanced trauma life support and rule out other associated injuries. Don't never ever forget. Am I right? So never forget whenever there is injury, even if they have not told you, tell we have to rule out any other associated injury. Okay. So never forget this thing because you can easily miss. IUP is like how like which like okay, with reference to IOP, what will be your concerns with reference to IOP, where the concept of IOP will be bothering? Yes, Asham. In airway management, am I audible? Has anyone else want to talk, please?
Yes, sir,
Assam.
audible.
Okay, so Assam, you tell me, please. What will be the concern of IOP and penetrating eye injury?
Sir, basically we have to maintain ocular perfusion pressure. So any surgeries in IUP during the time of laryngoscopy, any surgical manipulation, or during the time of induction what kind of drugs we are giving, we should be concerned about it. Like uh, ketamine, succinylcholine. These are
Succinylcholine.
known to raise intraocular pressure. So we will try to avoid them. But airway assessment of the patient is very necessary. If we are anticipating a difficult airway, so we should avoid giving rocuronium, and we should think of giving an induction agent like propofol or thiopentone, which can neutralize the effects of increased IOP caused by succinylcholine.
Okay, so here they can ask you, which maybe I am not recalling exactly. How much IOP is increased with succinylcholine?
Sir, I'm not sure.
You should know. I don't recall. But you should be knowing
Uh,
how much potassium it increase, how much IOP it increase. Please, IOP
Point
or
0.5
ICP.
milligram.
Sorry?
Potassium is
Potassium potassium effect is known that it will reach to lead to rise of 0.5 to 1 milliequivalent per liter per
For
DL.
how much time?
Sir, this I don't remember.
You should know. Okay, and what about IOP? You are Aslam, you are telling, Dr. Aslam?
Sir, I was also only aware about the potassium concentration, not about exactly the measurement of IOP.
Okay,
Sorry.
anyways, this is one question which I can recall. Please, you should be knowing about it. Okay, and then they can ask you, because whenever they're asking this question in table Viva, they can ask you that there are two. There is one in which all they remove the eyeball, and there is one evisceration. I don't remember. This is one terminology you should be knowing. Just a second.
Sir, Google says 9 millimeters of mercury after 6 minutes.
9 millimeter of mercury.
After 6 minutes of administration.
Okay. So just a second, please.
Sir, it averages up to 8.2 millimeters of mercury, and it may rise up to 9 millimeters of mercury up to 6 minutes.
Very good. Where is penetrating? I think there was an article on penetrating eye injury. Let me find. Anyways, we are just wasting. So actually, there is two concept in which one they remove all the eyeball, and in which they remove some part. I don't recall the word. Penetrating eye injury. This will be not the important part. The important part will be with reference to use of succinylcholine and airway manipulation. So you have to outweigh risk versus benefit, but priority is given to airway, not IOP, because if you lose the airway and patient aspirated, that life will go. Of course, there are certain ways by which you can have some effect. Like what about precurarization? Will precurarization help? What is difference between precurarization and priming? Yes, Bali?
Sir, giving reduced doses of tritium. Sir, giving reduced doses of tritium before succinylcholine, but it does not affect intraocular pressure. It will affect intragastric pressure. It will affect the myalgia post-operatively, but IOP surge would not be decreased by this.
Okay. So, and what is difference between priming and precurarization?
Sir, giving reduced doses of non-depolarizing before depolarizing is precurarization, I think so, and giving
No,
reduced doses of suck before.
no, no, no. Before sucks, it is precurarization. And giving some dose before giving the original dose of muscle relaxant is priming. Okay, the name, just like we prime the lines, so the priming is that one. So if
Right.
you give 1/10 dose of atracurium before giving induction agent, and similarly if you are giving it before suxamethonium, so the requirement of suxamethonium will increase or decrease. If you do precurization, the dose of suxamethonium is increased or decreased or same or what?
Increased,
Why?
because it has blocked the same receptors that are already blocked.
Actually, suxamethonium needs receptor. So if receptors are already blocked, it cannot affect in the way it should. Okay, so then we need more dose. That's the concept. When because it's acting on the acetylcholine receptor. That's the same reason there is resistance of suxamethonium in myasthenia gravis, because in myasthenia gravis there are reduced acetylcholine receptors. So that's the same concept. Okay. So in eye surgery, what else you need to know? You need to know about effect of various medications on intraocular pressure, this penetrating eye injury. They can ask you a few words about blocks, retrobulbar, peribulbar, and subtenon. Uh, like in which one you need to block facial nerve separately?
Sir, cataract surgery.
No, no, no. Among these three blocks, I think in retrobulbar, you need you don't need to block facial nerve. It is blocked alongside. But in peribulbar, you need to block facial nerve separately. You should uh,
So I think
you
in
can have.
retrobulbar facial nerve is separately blocked.
I don't remember. I'm sorry, but I remember this thing that in one of them you don't need to block facial nerve, and one of them you need to block. Okay, so you just have a look. Uh, I'm sorry, I don't recall because these things if you don't do, you forget. I think maybe our reconnaissance may be better than that. Anyways, I'm sorry, I don't recall this thing, but please note down the question which I have told you, and it may help. Just try to find out the answer. Okay, so what other eye problems can occur in anesthesia? Like corneal injury, pressure related to eye, this one, perfusion pressures, which occur in prone position. Prone position is not only because of direct pressure, okay? It's because of hanging of eyeball that also affects. And then the hypotensive anesthesia, okay? Hypotensive anesthesia also affects ophthalmological blood flow, okay? Then another thing is use of tranexamic acid, because tranexamic acid is the microemboli, which are usually washed out by the fibrinolytic system, are blocked by tranexamic acid, which is antifibrinolytic. Okay, so it is one of the differential diagnoses of transient blindness after anesthesia. Okay, and is it mandatory to put ointment all the time? What are the problems if you put ointment?
Sir, it can disrupt the aqueous flow of the.
So they might
Ac-
contain anticholinergics that may lead to tachycardia as well.
no, simple ointment. It's a very simple answer actually. Ointment can cause blurring, and post-operatively it is one of the factor for delirium because patient will be having blurred vision. So it can create problem. Okay. So you can wash it, but usually they are oil based. So they are not clearly washed with the water. Okay. Yes. Anesthesia has a lot of things which are not anesthesia. Anesthesia has everything which is other than anesthesia. Okay. So I can, if you can just have a look on the articles and you might find something which we did not do. Okay, so I think I will stop here and tomorrow afternoon I will send the link and we can, if anyone wants to discuss any specific topic, just let me know, please. So thank you very much and thanks for listening. Bye bye.